Richardson. I'm the director of MCT2D, the Michigan Collaborative for Type 2 Diabetes. This is our 6th regional meeting that we've held in the last couple of weeks. And I'm just going to give you a little bit of an introduction about the Quality Collaborative, and then we have a lot of stuff to pack in for the next 2 hours. There'll be some discussion and some chances for you guys to mix and mingle with the other people in your region. But let's get a little bit of an introduction to start with of the collaborative. So we're going to talk about where we've been, what we've been doing for the last year. The collaborative started about a year ago. Where we're now, that is with our first set of regional meetings that we're here doing right now, and then where we're going. So many of you in the room are practice clinical champions. Some of you may be PO clinical champions. Raise your hand if you're a practice clinical champion. Maybe? Not sure. All right, how about if you're a PO clinical champion? Some of you may be both. Okay, it's interesting that you don't know whether you're practice clinical champions or PO clinical champions. We've not experienced that before, but we'll work on that with you guys. All right, well, some of you may be representing practices, and some of you may be representing physician organizations. One of the things that we've done in the last year is we've done an assessment of readiness of practices that are part of the collaborative to implement some of the newer type 2 diabetes initiatives that we were talking about. So you may have answered some questions about whether or not your practice is ready to implement some of these things. We shared the goals and expectations of MCT2D with you guys, and we identified the individuals at each practice and at each PO, or the leaders at those practices and POs. Most of you have probably done the 6 training modules. Can you raise your hand if you completed the training module? So most of you have. And then we initiated the data dashboard for MCT2D. Some of you may not have seen the data dashboard. Good news is you'll see it tonight. So we're at our first regional meeting, set of regional meetings. We have 7 total regions, and this is our 6th meeting of those 7 for the first set. Tonight, you're going to have the second dashboard, the second piece of the dashboard data, and then some of you are working on case summaries for patients in your practices that have been exposed to some of the newer interventions. We're launching a learning community, which you'll hear more about tonight. And then we have a patient advisory board, which we'll also hear more about tonight. Where we're going, the big picture, we're looking to create a learning collaborative around type 2 diabetes management. Lots and lots of things have changed in the way we treat type 2 diabetes in the last 5 to 10 years. So much has changed and so many new things have come out with medications, with technologies, with diet recommendations that it's hard to keep up. The good news is it's all good for our patients. The bad news is it's just extra work and burden to stay on top of all the new changes. So our job is to make that easier for you so that you can make it easier for your patients. Currently, MCT2D is a statewide collaborative that includes 264 primary care practices, 15 nephrology practices, 14 endocrinology practices, a total of 750 participating physicians. Quality collaboratives like MCT2D have existed for a long time, but you guys may never have heard of them before. Traditionally, they tend to be part of a hospital-based system. They tend to focus on surgical problems, acute problems, and this is the first CQI, clinical quality collaborative, that has been focused on primary care outpatient issues. It's a very different issue. It's a very different set of data that we look at, a very different group of people that we're talking to than the traditional CQIs. CQIs are funded by a special program through Blue Cross Blue Shield, but just because Blue Cross Blue Shield is paying for the coordination and incentives doesn't mean that it's only for Blue Cross Blue Shield patients. Everything we do is all payer, all patients with type 2 diabetes. There are some things where we're restricted to Blue Cross Blue Shield data right now, but that's going to change. And we're gradually adding data to make it an all-payer database. So you guys, those of you who are clinical champions, you have a special role. This is sort of a train-the-trainer model where you're here to learn what we're doing with the collaborative and take some of that information back to your practices and show it to the other people in your practice, the whole team. We don't restrict to physicians. We have nurses, dietitians, pharmacists, everybody who takes care of type 2 diabetes in your practice. Here's the list of clinical champions from practices that we have right now. And what you'll see when it starts over in a second is that most of the people are physicians, but we have a pretty substantial number of nurses, as well as nurse practitioners, care navigators, pharmacists, registered dietitians, diabetes educators, physician assistants, and administrative personnel who are clinician or the clinical champions for a practice. So that's just a brief introduction of where we are right now, what you're here for, how we got you here. So thank you for coming. We know that the last 2.5 years have been really rough. I'm a practicing family doc. I see patients at a Planet Health Center. It's been a rough couple of years. It's just, we're not trying to make it rougher for you. We're trying to make it better for you. If there's something we're doing that's making your life worse, tell us and we'll fix it. We'll make it better. Our job is to support you in caring for your patients, doing a better job, making sure you have all the information, resources, and tools you need to really improve type 2 diabetes care across the state of Michigan. So here are the color-coded regions, the 7 regions that make up MCT2D across the state of Michigan. Here is your region. You may recognize the tag that represents your own practice. And when you signed up, you got asked a question about what you wanted to be the symbol that represented your region. And those of you who voted picked the gray wolf. So you guys are the gray wolves from now on. When we have our statewide meeting, which we will have once a year, the gray wolf region will be represented there. An interesting thing about this picture of a gray wolf is that it was actually original artwork done by our design team. We take design of materials facing patients and facing providers very seriously, not just to make them beautiful, which they are, but also to make them usable and easy to find the information you want on them. We have a design team that's very talented. If you think of something that you wish you had, if you think of a handout for a patient or a brochure you can teach your residents with or anything, tell us what it is. We'll get our design team on it. So there are 3 groups, and I'm not sure they're totally, this is a different kind of setup than we've had at our previous meeting. Most of the time we've had little tables.
We'll have to spin like the 3,
Spin around.
turn around and talk to the 3 behind.
So we've got group 2, group 1, and group 3. If you guys could introduce yourself within your group to each other, say your name, your practice location, your role in the practice, and then if you have time, talk about challenges that you think are unique to your own region that it may make it hard to implement some of the MCT2D initiatives. And there's just 5 minutes for that. It'll be brief, but then we'll have more time to have discussions a little bit later.
Yeah, this is the whole politics.
We have pharmacists.
This is gonna be your passion. It's hard to get. Yeah. So it's kind of like my name's Kelsey, I'm a care manager at I don't know, we always go around the circles.
Yes, I understand. Two sections. I've seen you on primary care meeting videos.
Okay.
I missed that one. That was the.
Where my integration program for I've been over here. I work at. Mostly right, or they put their $4,000 deductible first.
I don't think my challenge is different from anybody else's. We're just pumped. We're being crushed by the administrative burden.
Yeah, I mean, I guess that's
And the change is pretty hard.
part of it was just really
It's just a lot of stuff. It's a lot of rules, made rules, and what it uses stuff. And it's always been nice.
Do you
Office opened in 2019.
Yeah.
So.
All right, well, guys, we're gonna, I see lots of good discussion, but we're gonna bring it back together. I promise there will be more time for discussion. That was just a teaser. We're gonna talk briefly about the tools that we've already developed and then about the dashboard, so that will give you a little more context of what MCT2D is working on. So first of all, the most important thing you can take away from this meeting is where our website is. MCT2D.org is the URL. And on MCT2D.org, we want to show you a couple of really critical tabs. So the first really critical tab is right up at the top of MCT2D.org, and that says point of care tools. If you click on this button, your browser will open a page that has clinically relevant things that you might want to use right while you're talking to a patient. We have a whole lot of tools we developed, and you can see all of the tools we've developed are linked to under the resources tab. But many of the resources are for references about some of the initiatives, background information, more reading tools, not something you would reference right while you're sitting in front of a patient. If you want to focus on, if you're sitting in front of a patient, you want to use stuff under point of care tools. You can find the point of care tools under resources also, but lots of other stuff as well. And then the last thing I want to point out on our website is this Contact Us tab. If there's a tool that you want and you can't find, first of all, it might still be there. I can tell you where it is for you. But if it's really just not there, tell us what you're looking for, and we'll work with you to make it. And then we'll add it to the resources list. So that's where you can tell us when you have something you want us to do with resources or tools or the dashboard or whatever. So let's go over a couple of our most important tools. Again, these are point of care tools, things you might want to use while you're actually seeing a patient. The first one is our coverage by payer for SGLT2 inhibitors, GLP-1 receptor agonists, and CGMs across the major payers in Michigan specific, and updated almost daily because it's changing pretty rapidly. For that reason, it is only available online, people have been downloading it more than any of our other tools. It's the most used tool we have. But going to the website, clicking on point of care tools would take you to this form as well, and it will be more up to date than if you download it and print it out. Available on a folder at your seat is this patient assistance programs for Medicare Part D to help those patients who are trying to get these medications but are in the donut hole for Medicare. So there are ways to get that covered as well. And then the patient senior savings models for those patients who've signed up. And then the last thing is medication copay savings card programs, where you can find ways to help people get their copay covered. The last two here, the patient senior savings model and medication copay savings card programs, are things that you might actually want to hand to your patients. And there are stacks of them back in the back corner there by the coffee. And so we sort of broke down the tools into sort of three parts. The ones online only, which is mostly just this one coverage one. The ones that are available at your seat, where we thought you want just one copy of it, but it was important. And those available in the back, where we may want to pick the number of copies you want to take home with you to pass out to your friends or patients. So we also have a section for clinical decision-making tools. And these are not, they're partly point of care, but a lot of them are reference material or getting yourself familiar with these tools, with these interventions. So the decision guide, should we put this patient on an SGLT2 inhibitor or a GLP-1 receptor agonist? Depends on their comorbidities, on their contraindications, et cetera. And so we walk through that. And then dosing guidelines for the different medications. And then the very last thing over here is precautions. For both SGLT2 inhibitors and GLP-1 receptor agonists, there's a precautions page. These drugs are incredibly powerful and incredibly effective, but they have some issues. they're not to be taken lightly, partly because they are so powerful. They cause some side effects. They have some contraindications. And if you're going to be prescribing them, you need to know what those things are and be confident. So we've tried to make a summary as clear as we can, the things that are sort of precautionary, the things that are serious, the things that are absolute contraindication, so that you can go through that. Again, there's for both SGLT2 inhibitors and GLP-1 receptor agonists. And then the last thing is a section for patient-facing tools. These are things that your patients will see and read and use. And the majority of these are related to the low carbohydrate diet. And so there's a low carbohydrate diet tracker that helps people figure out how many grams of carbohydrates they're eating at each meal. There's this page, which actually has pictures of individual foods and their carbohydrate loads for a standard serving. And then the last thing is a daily tracker with more detailed space for more details. Lots more patient-facing tools coming soon. We've gotten a lot of feedback from our previous regional meetings about what kinds of patient-facing tools might be useful. If you have ideas for a patient-facing tool, let us know as you walk out the door this evening, or click on that button, contact us on the website, type it in, and we'll get to work on it. So now I'm going to hand it off to Jake, who's going to do the dashboard demo for you.
Hi everyone, my name is Jake Reiss. I'm the Quality Improvement Specialist for MCT2D. Thanks for coming out tonight. We really appreciate it. Before we get right into showing you the dashboard, I'm going to go through just a couple of slides to set the stage here. So the primary question we get asked is, who has access to the dashboard? The answer is that really that's anybody that wants it. So if you're here and you want access to the dashboard and you work for either a PO or a practice and you want access to the dashboard, you can have it. The process to getting that is to reach out to your PO, your physician organization, clinical champion, or your liaison that you communicate with at the PO. And they'll be able to get your information from you and submit a ticket to the Michigan Data Collaborative, which is our vendor, to get you access to the dashboard. There are a few POs that do plan on providing their practices downloaded reports in lieu of the direct access. However, If that PO is yours, and you still would like access, you can ask them about it, and I'm sure they would be happy to oblige. Also wanted to talk a little bit about what the data sources are that are currently in the dashboard. So right now, the dashboard is limited to Blue Cross Blue Shield claims data, as well as PPQC data. So the PPQC data is the medical data. Essentially, it has the values that we're interested in at the moment, which includes like weight, A1C, blood pressure. It is limited in the types of clinical data that it has, and so we are working on additional data sources in the future. But of note, just because that is all the data we have at the moment, I do want to make it very clear that the CQI and all CQIs are all patient, all payer initiatives. These is really meant to benefit all of your patients, not just patients that have Blue Cross insurance. By the end of this year, we're hoping to have all payer PPQC data to that end, as well as Blue Care Network claims data. Future state for 2023 and beyond, we're hoping to add what's called Ccda data. This is a different form of or architecture of clinical data. And we are hoping that this will bring in a number of new values, such as more kidney-specific labs and more metrics of interest, so we can make the dashboard more robust and more useful for you. We're also hoping to incorporate Medicaid claims and other payer claims data as well. All right, and then one last thing before the demo. Want to make sure we level set about what a pharmacy carve-out is. So for those of you that know what this is, feel free to disregard, but I know that one of the things that we hear all the time is, well, I looked at my patient's insurance and they have Blue Cross Blue Shield and it's a PPO, and I went to prescribe a CGM and there was all these different things that they told me I couldn't, I needed prior auth, and it just wouldn't go through. How come? Well, the most common reason for that is that the patient has a carve-out. So carve-outs are when an employer-sponsored benefit has carved out their pharmacy coverage directly with a PBM, a pharmacy benefit manager, so that that coverage is no longer a part of their medical coverage. And it's not always clear which patients have that and which patients don't. And so how do you tell? Well, we're hoping to make that a little easier. There is a part on the dashboard, which I will show you. Again, we only have Blue Cross patients at the moment. We're working on that. That will tell you if they have a carve-out and if they do not. And that can be used to identify whether or not that patient is going to have some prior authorizations or something like that, depending on their coverage level. All right, so I'm going to switch over the screen here. All right, so when you first log into the dashboard, this is what you see. This is an attestation page, simply that you'll click that you agree to for the proper use of PHI on the dashboard. After you click the I agree button, the dashboard is going to update and it's going to take you over to the patient list page. Well, maybe. And just caveat, the dashboard is querying databases, so it does perform slightly slowly, but it does usually get there. All right, so this is demo data, so if you see some wonky numbers, don't read into it. This is all fake patients. As you can see, we have Jane Smith from Practice A right now. So this is the dashboard. This is where you come to after you do the attestation. Our guide bar is at the top here. You can see far left is our attestation, which we just accepted. And then after we did that, it takes us over to the patient list, and that's where we're at right now. We can see on the right here, we have this long vertical columns of patients. We have name, type 2 diabetes, age, A1C, BMI, and weight. And you may be asking, why is there a type 2 diabetes column? I thought all of these patients had type 2 diabetes. You're correct. However, what we did for the dashboard purpose is that we wanted to make sure that we were bringing in patients both that have a documented diabetes diagnosis as well as ones that may not have one through claims data there. So if a patient has a type 2 diabetes diagnosis, they're brought in. If they don't, then it looks to see what their A1C is. If it's greater than 6.5 and they do not have a diagnosis of type 1, then they're brought in. And then third, if they also do not have a diagnosis of type 1, but also are on a diabetes medication, such as metformin, GLP, anything like that, they are also brought in. Of note, we will be adding a patient flagging system in the future, so that if there is a patient that should not be in the dashboard, then they would be able to be removed by you, the user. We are working on that. All right, so all of these columns are sortable. You can see that if we hover over right here, we have the ability to sort the columns. So if I sort A1C, you'll see that this will update and then it will sort it. I believe one click is from largest to smallest, and a second click would go the opposite direction. Yep. As you can see, demo data 16.09 A1C. All right, and so that's how the columns function here. On the left-hand side, we have some of our filters. And so you can see we have a filter for type 2 diabetes diagnosis. And so that's just a yes, no. We have age in years, A1C and BMI, which are all min max filters. Of note, you do not need to put in both. You can just put in a min or a max. After that, we have weight annual percent change. And so what this is saying is this is the amount of weight the patient has gained or lost in the last 12 months. And so if you want to find patients that are gaining weight, you would put your minimum in there. So for example, 5, that would be 5% in the last year. If you want to find patients that are losing weight, you would put in -5. All right, down further, we have our medications. And so we have insulin short acting, intermediate acting, long acting. And all of these drop downs include a number of different statuses for each of these medications, from active to either inactive or no entries whatsoever. We also have GLP, SGLT2, and metformin. And then we have this button on the bottom that says more filters. So if you click more filters, that's going to pop up another column of filters, which includes both systolic and diastolic blood pressures, as well as statin status, sulfonylurea status, and other diabetes medication status. And so this other diabetes medication will include any diabetes meds that do not have their own column, own filters, such as like a DPP4 or something of the like. Question?
Would you mind putting it on full screen or zooming the page a little bit? I know
Yeah.
Mac, but it's kind of hard to see the line.
Absolutely. Let me see if I can. It's always a surprise when we get into the room and see how this is going to perform on the screen. Does that help a little bit? Okay, thank you. All right, so we have our other filters here in the more filters column. All right. So I'm going to go down here and I'm going to click less filters. So this loads. All right, so let's say we want to, for example, do a search for A1C. All I have to do, let's say I'm going to search for a minimum A1C of 6.5. I typed it in, and then I click anywhere outside of that, and the dashboard is automatically going to update, and will now filter that list to only patients that have an A1C of 6.5 or greater. There we go. And you can see at the top, our patient list count went down. It was 16 something before. Now, let's say we want to do a filter that has a number of variables to it. That took a little bit of time for it to update. You don't want to wait every filter you put in there for it to update. So you can click this button on the bottom, this pause button. So if you click pause, what that's going to do is it's going to tell the dashboard to not update until after you tell it to start doing it again. So we can put in a couple other filters, such as active SGLT2 status, active metformin status, and a BMI, let's say 35. And then we can hit resume. And now the dashboard will update with all of those additional filters we just added. Yeah, absolutely. Yes.
When you put in, the 6.5.
Yep.
Is that their most recent A1C?
It is the most recent A1C that we have. So currently our data, as of today, will be through January 31st. All right. This is demo environment, so it says November 30th, but as of today, our actual data is through January 31st of this year. All right, so as you can see, our list count is now 27, so it did the filtering. All right, so any other questions before I keep going? All right, so on our guide bar at the top here, we have renal patient list. So if I click over here, what you'll notice is that it's very similar, and there's only one main difference, and that is that there's a couple of new filters here. So as you can see, we still have the type 2 diagnosis, but we now have the Ccda diagnosis as well. And also whether or not the patient is under the care of a nephrologist. We also have removed a couple of filters here for simplicity. And the reason we have two different lists instead of having all of these filters on the same one is simply for dashboard performance. These are querying millions and millions of patients. And so sometimes things get bogged down. As you can see, the dashboard does take a moment to update and refresh each time. We're going to do a live filter here together. I know I just did one. We're going to do one over on the nephrologist page. So we're going to do a yes for each one of these for type 2 status, CKD status, and nephrology care. We're going to leave our A1C of 6.5. We'll remove our BMI, and we'll go ahead and hit resume. Here we go. Okay, so now we have a much shorter list. So with that search, if we wanted to start browsing some of these patients, we have a couple of different options. We can click on the patient and go into their patient profile, which I will show you in a moment. But if you want a quick overview of them, you can hover over this magnifying glass on the right-hand side. That'll give you a quick snapshot of the patient. So you can see that with hovering over that, we can see their date of birth, last A1C, BMI, blood pressures, and medication statuses at the bottom as well. You can do that for each one of these patients. Oops, I think I accidentally clicked on it. My apologies. Yep, I did. All right. So if we do want to get a little bit more information on each of the patients, did I lose my filtering? Over here, that's why. Okay. If we want to get a little bit more information on the patient, we can actually click on the patient. Anywhere on their row is a link. So I'm going to click on Kiana McDonald. We're going to take a peek at what her patient profile looks like. And so once you click on a patient, this is what you'll come to. So you have at the top here the demographic information for Kiana. You can see her gender, age, date of birth. Then we have her type 2 diabetes diagnosis. That's a yes or a no field. You have her practice and PO attribution, as well as this right here, the pharmacy claims data available for November 2021. Yes. And so what this is saying, yes, this patient has pharmacy coverage through their medical insurance. So they do not have a carve out. And so this patient has pharmacy coverage through their insurance. And that is evidenced by the fact that we have pharmacy. We're showing prescriptions down here for this patient in the bottom right. And so we can see that this patient has a short-acting insulin and a long-acting insulin prescription, as well as a CGM. So we actually are able to see claims for CGM as well for each one of these patients. In a future state, we'll be adding a filter for CGM as well, which we'll talk about in a little bit. These numbers on the right-hand side are months since last fill, as well as the actual fill date. For this demo data, it's all on the same date, just coincidentally. On the left-hand side here, we have some trends of their A1C, BMI, and weight. And so you can see that if we actually hover over one of these dots, we'll be able to see the date that that value was recorded from. And you can hover over each one and see the dates for each one. All right. Any questions as of now? Great. Okay. So let's say I want to make sure that I follow up with Kiana. I want to make sure she doesn't fall off my radar, and then I come back and check in on her. And I don't want to have to do that search that I did by putting in all of those different filters each time. I can go ahead and click this gray bar here that says inpatient follow-up list. Currently it says no. If I click that, that's going to turn yellow and it'll say yes. And so what that's going to do is shift this patient over to a custom patient group. Across our top bar here, we have the custom patient groups tab. And so if I click over to here, we can see that Kiana is now in here. And we're working on the user experience of this tab right now. But as of right now, in order to make sure this saves, what you have to do is scroll down and then go to where it says View Original. Once you click on that, you'll be able to save this custom patient list that you just created. So you can do follow up, and you could put in whatever you want for 28, and you hit save. And that way, you know that you have this saved, and each time you log back in, the dashboard will default to View Original. All you'll have to do is click View and then select the view that you saved that patient to, and you'll be able to go to that patient list and find that subset of patients once again. All right, the last tab at the top here is our user guide. This is all of the information that we've gone through tonight, just as a quick update. It does contain a multitude of different tips and tricks, and is fairly user-friendly, but as always, if you do have any issues, please reach out to the coordinating center. We would be more than happy to walk you through, do a one-on-one Zoom, anything that you would like. All right, any questions on the dashboard before I switch back to the PowerPoint? Great. Okay, just a couple more slides and I'm going to turn it over to Dr. Oshman. All right, so just as a kind of a spur of the imagination type thing, if our goal, for example, was to identify patients who could be a good candidate for a SGLT2 inhibitor or a GLP-1 receptor agonist, we may search for patients that are on insulin, that we want to get them off insulin, for example, that are on not on a GLP-1 receptor agonist, that are not on an SGLT2 inhibitor, and maybe are not well controlled, have an A1C of greater than 7, and maybe that could stand to lose some weight, have a BMI over 30 or something like such. That could be a potential search. We did send these slides out ahead of time, and so we do have some potential other searches that you have here. I'm not going to go through them, but they are in the slides that we sent out in advance of the meeting. So as of right now, we do have an update coming in the middle of June for more features, and the main focus of that will be the summary statistics. So what you guys are probably more used to with regards to quality dashboards is more summary statistics, looking at how your practice, your PO, how those stand up to other practices within your PO or other POs within a region, or the collaborative as a whole. And so that will be coming in June, as well as a couple of other things, as I alluded to before. The CGM filter will be coming, as well as a carve-out filter. So you'll be able to search for patients that either have or do not have a carve-out. We'll also be adding a preferred versus non-preferred status flag for GLP-1 and SGLT2 inhibitors, as well as a number of other additional kidney-focused labs, such as urine microalbumin and things like that. We do have a standard cadence for both data updates and enhancements. So right now, we actually are a little ahead of schedule. So our 5.5 data refresh was pushed out this morning. And so that data update has gone out. And then we are set to have that data enhancement that I just walked through go out on June 13th. And then we go through about every other month with either an enhancement or a data refresh. All right, so with that, I'm going to turn it over to Dr. Oshman, who's going to talk to you about some great news on the Medicaid front.
All right. Hi, nice to meet you all. Can you hear me? Great, I'm Lauren Oshman. I'm a family doc. My practice is out in Chelsea, Michigan, and I work at the University of Michigan. As part of one of my other hats, in addition to being co-director here at MCT2D, I have a board certification in obesity medicine. So that was my pandemic project. I went through all of the CME to do that certification, and now I provide some consultation services in our practice to the other physicians who I work with. So getting anti-obesity medicines covered for our patients is really important to me, and Michigan Medicaid did not cover them. So surprisingly, sometimes when you just ask nicely, you get what you ask for. And in this case, we were able to submit a request to Michigan Medicine as Michigan Medicaid, as they do with any cancer drug or rheumatology drug that comes out, and they did agree to cover this class of anti-obesity medicines. Historically, Medicare disallowed the coverage of weight loss drugs, of anorectics, and so when HIV drugs to help with HIV wasting came out, they actually had to get approval from Medicare to approve and allow these medications. So you'll still see that Medicare does not cover anti-obesity meds, and that covers then all of our state Medicaid plans. Each Medicaid state plan then has to go through this process. So Wisconsin has it, now we have it, and it's really a wonderful opportunity for our patients. When you look at that common formulary, you're going to see the medications that we're all used to seeing for treatment of obesity. You'll see phentermine and some of the other phentermine products. You'll see Qsymia, which is phentermine plus topiramate. At the very bottom there, you'll see Contrave, which is bupropion and naltrexone together. And then the drugs that we're most used to using for patients with type 2 diabetes, you'll see liraglutide under the name Saxenda, which is higher dose for obesity treatment, even for patients without type 2 diabetes, and Wegovy, which I think has the market on like Super Bowl advertising. I feel like for higher dose than Ozempic, same drug, semaglutide, branded for anti-obesity treatment. And so thinking about how this is important to us, it may be for a patient with type 2 diabetes with Medicaid who also has a diagnosis of obesity, and you'd like to use a higher dose, the anti-obesity treatment dose, you would be able to then prescribe Saxenda or Wegovy for that patient. The bad news is that many people have been prescribing Wegovy. I'm not paid by any drug manufacturer, but there are limits now on supply chain issues with that drug. So the good news is Saxenda is available for patients. I've had no trouble getting that, and so just thinking carefully in the next few months to a year as to how that is available for our patients in general. Question?
Our pharmacy, we have a 340B pharmacy, and we literally got an email today that said, please stop prescribing Wegovy.
We got the same email.
And so, yeah, they said, in order to maintain the supply for people that are already taking it,
Yeah.
so we've been switching to Saxenda.
Yeah, and for patients who are starting on the medication, Ozempic is the same darn medication, semaglutide, and so starting at the 0.25 and 0.5 dose of those medications for those who prescribe it is appropriate. Xenical is on there. That is a medication that makes you have oily poops. I don't prescribe it. I don't have any experience with it, so anyone who does can find me afterwards. Tell me about it. The prior authorization criteria, so certainly Medicaid needs to watch its dollars and make sure we're prescribing these drugs appropriately So the first several prescriptions that I sent in got rejected because I was not providing the appropriate information to Medicaid that we had predisposed for these medications to be covered. It's all evidence-based stuff. Patients need to have BMI over 30 or over 27 with one very specific comorbidity, and so that's hypertension, heart disease, diabetes, dyslipidemia, sleep apnea. There are age restrictions that are appropriate. Saxenda actually is approved for age 12 and up for children with very severe obesity. I think mostly that's endocrinologists using that drug, and then 18 and up for the other ones. Somewhere in our documentation, we need to attest that they don't have any contraindications, that they're not pregnant or lactating, and then we need to attest that the patient has had at least one attempt at weight loss in the last year. All of our patients have attempted weight loss. That's by the time they come to me and talk about it, that's something I can attest to. And then we need to attest that this is part of a comprehensive treatment regimen, which I think we would all agree with, and that is prescribing a calorie and fat restricted diet and an exercise regimen of some sort. The way I talk to patients, the plan that works for you is the plan you're going to stick with. I do think for some patients, a plan that's low in carbohydrates and high in fat is the plan that they can stick with. Medicaid didn't ask me. So I generally assume that if they're on a calorie restricted diet, it's restricting fat in some way. And I feel I can be truthful in attesting that. So, talking about all this stuff in our progress notes, now that I've been doing that, I've had no trouble getting these medications approved. The last bit of it is a renewal. So when we think about, are these medications effective, the same way we've been looking for A1C lowering with a diabetes medication, patient needs to have at least 5% weight loss in 6 months to continue the medication. And so there's unfortunately a second bit of paperwork. But again, I feel like this is going to be a benefit to our patients. We're going to try to, again, make it as easy for you as possible. So we're going to have a online webinar on the 17th at 5:30 to go over this in more detail. We'll share some of the tools we're building, like dot phrases and other things you can use in your practice, and we'll talk in more detail about medications for those who want to learn more about how to use them in your practice. I feel like we're all really comfortable with the GLPs, and we use the other components of the other medications for lots of other things, and so it's just a new skill for us. But we'd love to see you there, and hopefully we'll have that taken for people who aren't able to make it. So I'm going to turn it back over. Any questions you have, or if anyone wants to talk about that afterwards, I'm happy to stay.
All right. We get a chance to talk within your groups again. There are some handouts, and each group has one of these, which is a set of questions to contemplate and discuss with your friends. And there's also this piece of paper. Towards the end, I'm going to give you about 10 minutes. Last couple minutes, I'm going to say, write down your questions, themes, topics on this. If there's something that you didn't get an answer to, or you all had the same question, or you all wanted a resource, write it down here. We're going to use what you write to plan what we're going to do next with our design team. So start by either, if you have questions you want to discuss that aren't on here, that's fine. But these are sort of to help you get started. And then at the end, write down what you talked about here. Each group gave me 1 or 2 comments. Each group said coverage for CGMs. That's the main issue. So let's talk for a minute about coverage for CGM. And then there was also a comment about integration of CGM into your workflow at your practice, which I think is also really important. So first of all, CGM coverage is evolving very rapidly, meaning every single payer is thinking really hard about whether they're going to start covering more and more CGMs. We're working, and you'll hear a little bit more about this later with Medicaid, specifically on the CGM issue. And we have the backing of the American Diabetes Association lobbying team, working specifically with Medicaid in Michigan to cover CGMs. So we'll talk about that in a bit. Actually, I think it's our very last slide of the evening. So we're working with all the payers in Michigan around CGM. Every single payer is interested in hearing what we have to say and thinking about it. It's really important to understand that CGMs can be prescribed either under a pharmacy benefit or a medical benefit. So remember, we talked about the carve out. You might have 2 different plans, your medical plan and your pharmacy plan. And sometimes you can get it on the medical plan, but not get it on the pharmacy plan. Sometimes you can get it on the pharmacy plan, but you can't get it on the medical plan. When it's on the medical plan, it's usually referred to as durable medical equipment. When it's on the pharmacy plan, you go pick it up at CVS. So it's complicated to know even if your patient has coverage for the CDM. You have to know whether they have a car out, you have to know who covers what. And it is difficult to figure it out. But more and more payers are starting to cover it for type 2 diabetes. And there's more and more data coming out to support covering it for type 2 diabetes, which is driving some of that change. So I expect you will see a lot more coverage in the next year or two for CGMs. There are some sort of creative thinking around what might be covered by Blue Cross Blue Shield, including some bundles that wrap together a CGM, a scale, and a blood pressure cuff with remote monitoring. So there are things will come up. Things will come out soon. The other thing is that we are working on also helping practices figure out how to use the CGM data, how to capture, review, document the CGM data that you're using, how to do the technology so that you can get the actual data integrated, or at least a port integrated to your electronic medical record. And Jake, actually, who did your dashboard demo, is an expert in dealing with these devices and the data. So if you have specific questions about CGM data integration, you can definitely direct those to him. But one of the things that we've noticed is that both for prior authorization for CGM coverage and for data integration, every practice does it differently. And so some practices aren't doing it at all. Raise your hand if your practice just doesn't deal with CGM yet. So we got a couple of those, and that's actually, for most of the time, we have rooms full of people that have never seen a CGM before. So many of you have. But the way that you do that is those practices that do use CGM. Was wondering if we could get a couple of you just to speak up about how you integrate CGM into your practice. And one of the things we know is that small practices have a very different set of resources than large practices. So what works for a large practice probably won't work for a small practice because the people aren't there. So is there a small practice? Are you a large practice?
Small and large.
You're a large practice, okay. We're gonna do small practice first, then we're gonna come to you. Is there somebody who's in a small practice, 1 or 2 providers, a couple of ancillary staff? How do you manage your CGM? Are there no small practices in the room?
We're just 1 doctor, 2 PAs, but we're just, most of our CGM people that need CGMs go to the specialists, go to the endocrinologist. We have a couple of patients that have CGMs that we see and the endocrinologist sees. I was telling them we have a woman that was a pre-diabetic, and I don't know what insurance she has for life of me, but she was interested in Freestyle Libre. She was terrified. Her dad had 2 amputations and all this horrible family history, and she's like, I don't want to get like that. So one of our other care managers gave her a sample of Freestyle Libre. It ended up being covered. So she's just over the moon because her A1C wasn't very high anyway, and it's lower than that. But I mean, she's not even on any metformin. I don't know how she got it covered. I don't know, but it's covered, and so she's happy, and she's just monitoring that. And we're seeing her every 3 months because we want to make sure she stays in that pre-diabetic range. But we really don't have. And I honestly, when this was mentioned, at least one of our PAs said, I don't think we have time to monitor, see blood sugars all the time.
Yeah, that's really interesting. So your solution in your small practice without the resources is to send them to endocrinology for their CGM work. And in some areas of the state, there are endocrinologists sitting there waiting to take care of your type 2 diabetics who need a CGM, and that works great.
It used to be only the severe or the brittle or the,
Right.
whatever you want to call them, really needed or were recommended that they have that.
But it's creeping up, it's gradually accelerating, actually
And
rapidly.
it should be, because it's preventative. That's
Yeah.
a good thing.
So At Michigan Medicine, I can tell you that the endocrinologist would shoot us if we did that. They would literally come and go back to our office. You know, at the end. So we can't refer our patients for that. Although we sometimes, if we have trouble with prior auth, they have a team of 5 prior auth people whose lives are entirely devoted to prior auth, which is a sad thing. But they can figure out how to get a CDM for most of our type 2 diabetes patients. And if we have trouble, we can use their expertise on how to manipulate the system and get them their CDM. But we don't usually refer to our endocrinologists because there are not enough of our endocrinologists, and they have too many other diseases that they're managing. So we're expected, the family docs and internists are expected to manage the CDMs, although not everybody does. There's usually 1 or 2 people who know how to use it. As far as integration, we have a system at Michigan Medicine called Gluco, which supposedly brings in all the data, but actually doesn't work with half the systems, and it's sort of just getting rolled out. Most of the primary care family docs tend to use the systems that are provided by the company, like the Libre view system for the Abbott Libre and the Dexcom. What's the next Clarity. So we tend to use those because they're actually pretty user-friendly and easy to get, and the patients can do it quickly and works pretty well. Let's go to a large practice and hear what happens from a large practice perspective around managing.
Wow.
Hi, I'm Abby. I'm a nurse practitioner in Battle Creek at Day One. We're a family practice of about 15 providers right now, and I'm kind of the diabetes lead. And I started using CGMs last July when I just found out about them, and I had met with a Libre rep and just kind of taught myself, and she kind of taught me along the way. And what happens is, you know, we have samples in the office. I see a patient. I explain to them what a CGM is. I say, hey, I really think that you'd like this. Let's try it. Let's see if your insurance covers it, and we'll go from there. So then I grab the sample and I put it on them, show them real quick how to put it on, and then I have them download the app on their phone. They used to have the reader, but they don't have those anymore unless, you know, somebody who doesn't have a smartphone, you could order one for them. And then if I don't have enough time, then I grab a care manager. We have a team of about 6 of them. And I'm like, could you guys show them the app, show them how to put it on, how to scan. But I try to do it with my patients. And then when they come back, then if they have the reader, then I just download it to my computer and download it to their Leak Review website. And it shows the trends, how often they're in target range, and your goal is 80%. And, you know, it can show like for the last 14 days, their A1C was, you know, 7.2 versus what it was before. So it's really cool. And patients really respond to seeing it in a graph form. And then you can, you know, I just basically print out that report. I give one to them. I keep one and we scan it to our system. And then you can bill for that reviewing as long as it's over 72 hours as well. And so I just got Dexcom, and now I'm going to do the same process with Dexcom. And, yeah, I know. I just don't want to.
All right, so you can see that there's lots of different ways to work with these things, and each practice is going to have to find their solution to the problem of how to deal with the CGM data. There are billing codes that you can use. There are different strategies that will help with that as well. Yeah.
Can you spend like 2 minutes or 1 minute, just a really brief overview, like on the Libre viewer, like what that entails? I'm familiar with it. I've seen reports that my care manager prints off, but if I was doing something like that, how complex and what is that?
It's super easy. It really is. You go to the Abbott Libre website, you type your name in, it asks a couple questions, you put in a password, create an account as a provider. It takes 2 minutes. It's not painful. And then you get a number, code. That's your practice code number. You give that number to your patients who have the Abbott Libre on them, and they type it into their app. And then the next time you log into your account on Leak Review, there's their data. Like, that's literally all it is. It's pretty, I mean, and it's seconds. I've done it live. I've like said, here's the code, and then it's like, oh, there's your data. Okay. I don't know how they make it work that fast, but they do. So it's actually really user-friendly, really easy to create an account. The other thing is they will come and teach you how to use it. And we have the videos linked on the research website. So they have it made a bunch of videos, how to use Clarity, how to use lead review. They walk you through it. It's great. It's not hard. It's not hard at all. And Jake can walk, Jake taught me how to do half of it, the stuff, and so he can walk you through it if you get stuck or if you have a question or something that's not working.
If you don't want to talk to a rep, I'll do a one-on-one Zoom with anybody.
Yeah, the last thing is that your patients can get one CGM from Abbott. Does Dexcom have the one CGM free thing?
They don't.
They don't. Abbott will give your patients one free CGM. 14 days. It's not good enough, but it's not nothing for patients that don't have any other way to get it. Yay. All right. So the next thing we're going to do is we're going to move on to our next topic. We have a sister CQI, sort of part of our group, which is called MKIC, Michigan Kidney something, Michigan Kidney. So they're the kidney part of the diabetes CQI. They're sort of their own CQI. They're sort of part of us. It's a little unfair. Anyway, Mike Heung is the guy who runs the Kidney Collaborative, focused on almost entirely on type 2 diabetes related chronic kidney disease. Mike is a nephrologist, and Mike is going to be on with us, not in person, but virtually. He is going to answer questions for you. A card-carrying nephrologist will be answering questions, but I'm going to give about a 20-minute presentation before that on some new things we need to know about chronic kidney disease, and that we want you to take back to your practice. And then Mike will come on and answer any of your questions. So if you have a simple question, I can probably answer it. If you have a nephrology question, wait for Mike to answer it. So first of all, as we talked about at the beginning, chronic disease is what we deal with. That's our business. That's our bread and butter. We're really, the diabetes CQI and the chronic kidney disease CQI are initiating the concept of these statewide quality collaboratives for chronic disease. So it's a little bit different. And part of our goal is to think about how we can best address chronic disease and prevent progression to renal failure in this case. So chronic kidney disease, something we've seen, all of us who take care of patients with type 2 diabetes have seen in our practice. It's pretty easy to define, pretty easy to diagnose. There's sort of two parts. There's the structural damage to the kidney and the functional abnormalities of the kidney. And those can be detected with two different tests. First with urine albumin, and secondly with declining EGFR. And pathologic abnormalities as well from a biopsy. Usually in clinical practice, we start to pay attention when the EGFR drops below 60. That's when we get into the stage 3A category of chronic kidney disease. But what we're pushing now, and what we think we have evidence for, and we have treatments that can help prevent progression for, is people who are before that stage 3 category to look at their albumin levels. So our big picture is stage 4 and stage 5 kidney failure, where you need a transplant or dialysis. Everybody knows, you know, that's the thing we're trying to avoid. Type 2 diabetes is the #1 cause of dialysis and kidney transplant in this country. And if we can prevent the progression, we can make a pretty dramatic population level effect on kidney disease. But the stages 1, 2, 3A, and 3B, we tend to not do too much for them. Sometimes we don't even notice that they have it. We don't put the diagnosis down on our problem list. We don't pay much attention to it. There's one intervention that it's been drilled into our heads that we should do for these patients. What's that? Lisinopril, right? So yes, hopefully you're all prescribing lisinopril for those who can tolerate it, or ours if they can't, to protect their kidneys. But we have so much more now. Things are different now. We have more treatments for stopping progression. And that's partly where the albumin comes in. So about 40 million US adults have chronic kidney disease. That's 1 in 7 of the general public. 1 in 3 of our patients with type 2 diabetes. That's a lot. This is a really interesting thing that says, this is the stage 1, 2, 3, 4, and 5. And this is the percentage of patients who know they have the diagnosis. Not surprisingly, the guys in stage 5 are the highest aware of their fact that they have chronic kidney disease. But what is very surprising is that the y-axis over here, which is the percentage for people in renal failure, is 50%. Half the people in renal failure don't know they have renal failure. That's bizarre. I don't understand that, but that's what they don't, the lack of education, communication with the patient. Some of them crash into failure in the ER. They had no idea that they were in renal failure. They may have been there for a while. The fact that, if you're in stage 3, which is definitely at risk for shifting to 4 and 5 pretty soon, the percentage is like 10%. 10% of people who are in that high-risk category for regression to needing a transplant or needing dialysis, only 10% know they even have it. They're even at risk. That's a problem. Especially if our goal is to prevent getting to those late stages. If our goal is to manage it, to prevent it, we have to know about it early on. So here's some data split out by gender and also by race category. And you can see that age plays a big role in risk for chronic kidney disease, but there's also a big split out by ethnicity and race. And men are at a slightly higher risk than women over time. And this slide is really about giving you hope that we can make a difference in population level rates of kidney failure, of dialysis, and of transplant. This green line right here is Native Americans. And what you can see is they started out with this incredibly high rate of kidney failure, all related to type 2 diabetes. And through a very concerted effort of the Indian Health Service to address early stages of chronic disease to prevent progression, they were able to drop that rate quite dramatically on a large population level. So we know we can do it. We know it's possible to dramatically reduce the rates of chronic kidney disease shifting into renal failure, transplant, dialysis. Of course, at the end here, this is 2013 data at the end, there's still disparities by race, but we know we can make population level shifts. It's possible to do it. It's been done. And that was before we had SGLT2 inhibitors. So from a conceptual model perspective, we're really focused here on the risk and the damage phases, the phases that never see a nephrologist. So if you're waiting for the nephrologist to intervene on risk and damage, they're not seeing these patients. It's us, it's the primary care doctors that have to intervene. We have to do it because they're not making it all the way to the nephrologist yet. By the time they get to decreased GFR, kidney failure, and death, yeah, then we have a nephrologist on board, but that's too late. So here's the punchline that the most important take home is urine albumin. Albumin is very helpful in understanding where people are in the risk phase of their kidney disease, and we're not ordering it on enough patients. Urine albumin in the urine is always abnormal. It's always a sign that the kidney isn't functioning properly. Because a healthy kidney is supposed to maybe filter out the albumin, but it is reabsorbed. And if there's albumin in the urine, when you do your dip or your quantitative measure of albumin with creatinine ratio, if there's albumin there, it's abnormal. That's a problem. And so it is one of the earliest signs that the kidney is deteriorating. This is what they call the chronic kidney disease heat map. Over here we have the Egfr ratings, stage 1, 2, 3A, 3B, 4, and 5. The ones you may all be familiar with. Most of my patients, at least, are 3A. I have a few patients who are 3B. They mostly have nephrology involved at this point. And then I have a couple patients who are closely monitored getting dialysis in stage 4 or 5. But the ones that we recognize that we have a lot of patients of is these 3A. And that's an Egfr of 45 to 59. What you can see from the heat map, the red is the people who are at high risk for dialysis or death, or needing a transplant. So you don't want your patients to get to red. If you got to red, you failed. Orange is right before that, yellow, and green is low risk. So the critical thing is that there are now rows of albumin levels. And A1 is normal, which is 0, to mildly elevated up to 30 milligrams per gram of albumin to creatinine ratio. 30 to 300 is moderately increased, and over 300 is severely increased. So it's a quantitative measure of how much albumin there is in the urine that we're looking for to estimate risk. And one of the things you can see is in our big 3A, stage 3A with lots of our patients in it, you can be yellow, a little bit of risk. You can be orange, getting there. You can already be on your way to failure. And so we can tell which one you are. If you know, but only if you order that albumin test. And in addition to predicting disease progression and all kinds of other stuff, it predicts all-cause mortality as well. So understanding how aggressive you should be by how at-risk the patients are is important to order that albumin test. Additionally, albumin in the urine is a therapeutic target now. That is, we can push the albumin in the urine down with medication. Sometimes we titrate the lisinopril up to a higher dose to get rid of the albumin in the urine. That protects the kidneys from further deterioration. Similarly, SGLT2 inhibitors can be added to bring that albumin down. If you can't get the albumin down, you're going to start to prepare for going towards that renal failure, dialysis, and transplant as an outcome. So urine protein testing. Albumin is a kind of protein, but it's not all protein. It's just a subset of protein. There are different types of proteins besides albumin. If you're testing for protein, you're testing for all the proteins. If you're testing for albumin, you're just testing for albumin. On a dipstick, you can sometimes see yes or no protein. You can sometimes see yes or no albumin. Sometimes you can see a quantitative summary of actual categories, how much protein or how much albumin. But that can be a little bit misleading as well. Usually it's a spot in our practice, at least it's a spot urine, not a 24-hour collection or anything like that. Our guidelines advocate for the quantitative urine albumin to creatinine ratio. And the ratio is because if somebody drinks a whole lot, has a very dilute urine, you may get a negative dipstick for qualitative albumin or qualitative protein, but that patient may still have a significant amount of albumin. It's just so diluted that it doesn't show up on the dipstick. Additionally, you may have somebody who's dry who looks like they have a lot of albumin in their urine, but it's just because they're dry. So the concentration of the urine really matters, and that's why we do the ratio. So the way you collect the urine matters. Spot is okay, but has to be a clean catch midstream. Avoid skin contamination because that can change the protein levels. Avoid strenuous physical activity. If you have a weightlifter or a marathon runner who does a marathon the day before they get their urine test, they're going to have more protein in their urine. And that's not a problem. Theoretically, you want to analyze that within 15 to 30 minutes. If you wait longer, it can give you a spurious result. The dipstick, this is an example of a dipstick that says 1+, 2+, 3+, 4+. On the protein level, again, it's protein, not albumin. We're looking for the albumin specifically here, but this can be helpful. And most of that protein, especially at the higher levels, is going to be the albumin. So here's a little bit of a map comparing the low, medium, and high levels of albuminuria. The dipstick tends to be here. We call it, again, normal, moderate, and severe. And on the heat map, it's A1, A2, and A3. And then you might use the old terms, which we're trying to get rid of because they don't make a lot of sense. Normal, microalbuminuria, and macroalbuminuria. People think that there's a molecule called microalbumin. There isn't. It's just albumin. Microalbumin is a bad name. So normal albumin, moderate level of albumin, a lot of albumin. That's what those really are. All right, so 2 myths that we want to make sure you go home with, knowing the new plan. We used to say if your patient was already taking lisinopril, there was no reason to test for microalbuminuria or albumin to creatinine ratio. That is no longer true because we have other treatments that we can add on top of the lisinopril to further push the albumin in the urine down as a therapeutic target. So now, even if your patient's already on an ACE inhibitor on the arm, we really highly recommend once a year checking their albumin level to understand if you've gotten the therapeutic target of really pushing that albumin in the urine down, if you should be adding another agent to protect the kidney. The second is, if you do a dip and it's negative qualitatively for protein, does that mean that you don't need to check? Because if there's no protein in the dip, how could there be albumin? How could there be a lot of albumin? Well, again, it's a concentration issue. If the dip is negative and it's a very dilute urine, you could still have moderate levels and even possibly severe levels of albuminuria. So quantitative albumin to creatinine ratio is the gold standard for this. We, as a collaborative, we're really focused on our type 2 diabetes patients, but there's lots of other people who are at risk for chronic kidney disease besides type 2 diabetes. Again, type 2 diabetes is the most prevalent group of people with chronic kidney disease in this country, but even things like bad hypertension that's poorly controlled put people at risk. Use microalbumin or albumin creatinine ratio for those patients to put them on the heat map, figure out what their risk level is as well. Many of those patients are now starting to get put on SGLT2 inhibitors as well. All right. And again, protein to creatinine is not the same as albumin to creatinine ratio. So the things that we all know, you want to control your blood pressure to keep your kidneys protected. Sodium restriction helps to keep blood pressure down, which helps to protect the kidneys. RAS blockade, ACE or ARB, and then avoid nephrotoxins, NSAIDs, weight loss, maintenance, smoking cessation, all the things we do sort of as a routine part of our family practice, internal medicine practice, whatever. The one thing that we really want to emphasize is that teaching your patients that they have chronic kidney disease, that they are at risk, and that they need to pay attention to their kidneys and do the things that they can to protect them makes a difference in time to falling off a cliff and needing dialysis or transplant. So education makes a difference. It's not going to solve all the problems, but it makes a significant difference in risk. So talk to your patients, make sure they know they have chronic kidney disease, make sure they know why you're being aggressive about controlling their blood pressure, why you're adding new meds, why they're taking that lisinopril, et cetera. There are self-management education programs that are available. Some of them are from the National Kidney Foundation of Michigan, where you can send your patients to get educated. And then once the patients progress to damage and decreased eGFR, that's when we start to think about more aggressive treatments as well. Again, we're still doing diet and exercise, blood pressure, weight, sugar, and avoiding nephrotoxins. But now we have exciting new news. And this is live footage from, according to Mike Heung, from an actual nephrologist's office when the trial data came out about SGLT2 inhibitors, protecting the kidneys from progression of chronic kidney disease. So these new classes of drugs, SGLT2 inhibitors in particular, have been proven to be dramatically effective at slowing the progression of chronic kidney disease. They do other things, of course. They help us control glucose. That's why we use them for type 2 diabetes. They decrease adverse cardiovascular effects in a big way. Dramatic. Cardiologists are now prescribing these drugs for cardiac protection. What we're really focusing on today, and actually one of the biggest effects, is preventing progression of chronic kidney disease to dialysis or transplant. The GLP-1 receptor agonists more than the SGLT2 inhibitors, but both classes do support weight loss and decrease insulin resistance. Both of them have been shown to decrease mortality as well. And the amounts of the size of the effects are huge. So here's an example of one trial on a canagliflozin, which is one of the SGLT2 inhibitors. Using a primary composite outcome of end-stage renal disease or doubling of creatinine or renal or cardiovascular death as a composite, there were 61 of those events per 1,000 people with the placebo and 43 per 1,000 people, patient years, with a canagliflozin. That works out to a hazard ratio of 0.7. You can think of it as 30% reduction in risk, which is massive. It's a massive effect on a population level. And we've seen this. This is one trial. We see it in every trial that comes out. Consistently, we are seeing these kinds of levels of benefit. So it's important to know when you start SGLT2 inhibitors, you will see a drop in eGFR. Here's an example of what it might look like. The black line here is if you don't put them on an SGLT2 inhibitor. The red line is the drop at 4 weeks in eGFR if you put them on an SGLT2 inhibitor. Well, that's a problem because if you're putting someone on a drug to protect their kidneys and it's dropping their eGFR, that just feels wrong, right? But there's a couple of reasons why it's okay. So the first thing is this drop is usually about 10% of eGFR. It's usually not huge. It usually doesn't take someone in stage 3A down to stage 4 and stage 5. That would be extremely unusual. The second thing is that it's not really causing any pathophysiologic damage to the kidneys. It's actually protecting the kidneys. And I'll show you how we know that in a minute. The third thing is that even though you get that 10% drop, it doesn't keep going down. It stabilizes, even goes up a little bit over the next year. And so, but if you don't put them on the SGLT2 inhibitor, you start to see that 10% drop at about a year, and it keeps dropping. So that it crosses with the placebo. Now, here's where we know that you're not actually doing intrinsic damage to the kidney with this 10% drop. When you look over here, you see if you stop the SGLT2 inhibitor, you recover that eGFR that you had at the beginning. Placebo, there's nothing to stop. You continue to see the deficit. And one way to think about it is the SGLT2 inhibitor reduces the pressure on the filter. The filter gets torn apart, the kidney gets torn apart, destroyed functionally by high pressure, doing a lot of filtering. When you reduce that pressure, you're protecting the kidney tissue. but you're also not filtering as much. So that's the EGFR drop initially. When you take this SGLT2 inhibitor off, get the pressure back up to where it was without the SGLT2 inhibitor, you see the filtering resume at its previous level. So some people, there's a big debate, should we be checking EGFR after we start an SGLT2 inhibitor? There's no guidelines that suggest we should be. Some people do, some people don't. The nephrologists tend to do it because they have patients that are closer to that stage 4, stage 5 range. The primary care docs with the stage 3 don't tend to order the EGFR. And sometimes it causes problems because it's like, oh no, it dropped. Now what do you do? This is really to focus on who's prescribing the SGLT2 inhibitor. Raise your hand if you have prescribed an SGLT2 inhibitor for any patients before. Raise your hand if you've initiated in the first person to start an SGLT2 inhibitor among your patients. So some of us wait for someone else to do it, and then we're comfortable once it's started, continuing it. Some of us have never prescribed it before. But the interesting thing to know is there's lots of people now who are responsible for getting these on board. There's cardiologists, nephrologists, endocrinologists, and primary care doctors. All of us are responsible for it. And there's some reluctance in each of those groups to actually write the script. The reluctance turns out to not be what you might expect when we talk to those groups. They don't want to step on other people's toes. If there's an endocrinologist on board, why would I be the one prescribing the SGLT2 inhibitor? The endocrinologist should do it. The cardiologist is like, well, I don't want to mess with their diabetes control. I'm a cardiologist. The nephrologist says, I think this person should be on an SGLT2 inhibitor, but it looks like there's already a bunch of cooks in the kitchen. I don't want to mess up things or make them go hypoglycemic. So how do we fix that problem? How do we make sure that somebody gets on one of these drugs?
My attitude is, I want to be the first one to do it. So that the cardiologist says, Dr. Thompson's taking good care of it.
That's a good attitude. I like it. I think, what we've sort of come to, what Mike has said to us and what we think works best with everybody is everybody at least talks about it. Everybody is on board with it. Everybody knows the benefits of it. Everybody encourages it. Wherever the patient's ready to start it, that's the person who starts it. So for instance, a patient with deteriorating EGFR may go to a nephrologist. The nephrologist may say, I really think you should start an SGLT2 inhibitor. The patient may think about it and say, well, I have to talk to my primary care doc to make sure it's okay. Go back to the primary care doc. The primary care doc insists, the nephrologist said I should start this medicine. The primary care doc says, absolutely, here's your script. Other way it might work is that the PCP may say, your kidney function is deteriorating. I think you should start an SGLT2 inhibitor. And they may say, well, I don't know how bad is my kidney, but I feel fine. My kidneys don't hurt. So why should I start another drug? They will go talk to the kidney specialist and let them tell you why you need another drug here. You get to the nephrologist, it's the specialist. They listen. The second time they've heard it, the nephrologist starts the drug. Maybe it's the cardiologist, maybe it's the endocrinologist. I don't care who it is, but everybody should be pushing it, talking about the benefits, supporting it. And if you get a patient who's ready to start it, you should be ready to start it for them. Write that script. And then communicating with the team is helpful. If there's an endocrinologist who's titrating insulin, they need to know that the patient just started an SGLT2 inhibitor because the insulin dose is going to go down. It is. And you don't want them to get hypoglycemic. So some communication strategies are important. So we have lots of tools to help you use these drugs. As we've already discussed, some of them are in the back, some of them are online only. We want a quick 10-minute small group discussion again about two issues. The first one is, do you test for urine albumin to creatinine ratio on all of your diabetes patients every year, even if they're on ACE inhibitors already, or not? And what are the barriers that would keep you from doing that? And then how do you coordinate with the other specialties when you're thinking about starting an SGLT2 inhibitor or GLP-1 receptor agonist? 10 minutes, go.
Sorry.
So while you're discussing this, if you come up with questions for a nephrologist, we're gonna have a nephrologist on the line with Tony McFadden. At the end of this.
The clip is right here. Okay, where was it?
Sorry.
Okay.
Bye.
Thank you so much.
Thanks for coming.
We're running a little tight tonight.
Are we?
Yeah.
Sorry.
No,
Taking
you're
too long.
You're good. We probably pulling after like 7-8 minutes if possible.
Okay. I will.
Mike's on the call. He's ready to go.
7:50.
Yeah, one at 7:50. Hopefully they don't have, because I gotta go through all the Jackie slides yet too. So
Okay.
it'll probably be a little over, but hopefully they're okay.
Okay. It's hard to. I know.
But doesn't quality texture. So I would like to make sure. It's one of the few things I can do. I mean, you're not on some other stuff.
I think that you guys do like the experience that you guys actually like in the office. Like what time is like their urine albumin? It should be easier. So that's the biggest
The second question.
There's like all these different kinds of things that you're working with. That's a process, like maybe that's not just ordering a different test or like really like only like how you don't kind of shape the same system like this is different things and then patients are like, oh yeah, no, my ones are the same. And if I pull up, a lot of times I pull up Epic and our system, no, there's different ones. Oh yeah, I forgot. Like, I think just the integrating of EMRs. Yeah, it is. Yeah.
Yeah, I appreciate
As far as coordination, especially
nephrologists are setting this
it's very easy.
and now they try to notice the
Endocrinologist, say I started up there and it's been really professional now.
So, yeah.
I mean, as far as referring, having a cardiologist, somebody else can get a my patient's gonna see a cardiologist.
Yeah.
Because then it's like, it's one day away, and very specialist, so chance it to be, but it's not, it's 3 months. Right.
I don't like that. I tell my question is like this is one of the things that I'm taking like this after baby one what do you take that for? Yeah, I told them not to.
Good, excellent, specialists, they communicate with us primary care people.
I
And,
say,
you
it's
know,
gonna help you with
respectful way, in a way that helps us.
And they're like, okay, whatever.
Most sometimes it's some.
Yeah. You want to or you're on a very low carb diet. I got all like keto. Yeah.
I get the hypertension.
Oh, yeah, yeah.
Every year.
Yeah, we've been pushing that as well. Yeah. Yeah. So
A few. That have done really well.
Right, it might not.
Somebody's already seen the neurologist.
Reminder for hypertension.
I can facilitate if you'd like. Yep.
Yeah.
Right.
You guys have kids?
Right.
Yeah.
All right. Dr. Heung, can you hear us?
I can hear you. Can you guys hear me?
We can.
Awesome.
All right. Hi, everyone. We have Dr. Heung on the call. If anybody has any questions for him, he is here specifically to answer questions. If you don't, that's okay too. But if you do, please raise your hand and I'll bring you the mic. Take your time.
Hey, everybody. Sorry I'm not there in person. I'm actually on service covering the hospital this week, so hard to be in two places at once. Although with the magic of technology, I kind of can sort of be there. So sounds like a lively meeting. So I'm sorry I'm missing it.
Yep, Dr. Heung was at our first 4, so if there's no questions for him, that's okay too. But we have one. I'm going to transfer you over here, Dr. Heung.
I guess my question is, in regards to the testing timeline for testing the urine, is that just if you're doing a dipstick? Is that the urine albumin creatinine ratio if you're ordering it? Does it make a difference?
You can do it on a random sample. So yes, if you're ordering a urinalysis on your patient, you can order a urine albumin to creatinine ratio at the same time, certainly. You don't need to wait for the urinalysis to come back. If it's positive for protein, that's obviously concerning and you still want to quantify it. But even if it's negative for protein, like Dr. Richardson mentioned, sometimes you can have significant albuminuria like A2 level or even occasionally A3 level with a normal dipstick. And that's because, as you know, the dipstick, it's a chemical reaction on that. So if your patient is drinking a ton of water and their urine is pretty dilute, it may not pick up on the dipstick, but they still can have significant albuminuria. So we do recommend getting both the urinalysis and specifically the urine albumin to creatinine ratio separately, but they can be done at the same time.
But is that 15 to 20 minutes? Is that 15 to 20 minutes where the testing has to be completed or the recommended time frame? True for both tests? That was my question.
Oh yeah, no, that, I mean, that is the recommended time frame, but honestly, most of the time that's a pretty unrealistic time frame for most places. So I think the spot urine sample is still accurate in most scenarios, even if it's a little bit longer than that, even if it's a regular sending to the lab.
Okay, thank you.
Sure.
One at the back here, Dr. Heung.
I've got 2 questions. One is with Invokana, a while ago, there were some worries about amputations and just in general, where the lay of the land is with SGLTs as far as that goes. And then I guess the other question is on some of our nephrologists, patients that we share with nephrologists, they're ordering the urine protein creatinine ratio, and what's the benefit of that? So especially coordinating care with them.
Sure. So for the first question, in terms of the risk of amputation, that was one of the early concerns. It was seen in the one study, as you mentioned. However, it was not seen with the other SGLT2 inhibitors. And actually with subsequent studies with the Invokana, it was not seen in those studies either. So I believe actually it's been taken off the black box labeling from the FDA. I honestly, in my practice, I still mention it to patients. What I mention is that, you should be getting regular foot care anyways, especially those patients with evidence of neuropathy. So it's really not anything different than what they should be getting. I like to mention it that it's there, but I mainly provide reassurance. I think some of the commercials still mention it, so they may hear of it otherwise. But I don't consider that a contraindication to using these medicines at this point. In terms of the second question, the urine protein to creatinine ratio is sort of more inclusive than the urine albumin to creatinine ratio, so it'll include a bunch of other things. It's a little nuanced in that if you have overt proteinuria, like your patient has florid diabetic kidney disease, and their urine protein to creatinine ratio is above 1. It's 1.5 or even 2 or something like that. Yes, I agree. You're not getting a whole lot by adding in a urine albumin to creatinine ratio at that point, simply because they have overt proteinuria. That's in the most severe range of A3. However, if you have you can actually have a normal albumin to creatinine ratio, for example, a 0.15 or 0.18, which is still under the normal limit of around 0.2, the normal threshold. You can have that normal urine protein to creatinine ratio, but an abnormal albumin to creatinine ratio. So in that sense, the albumin to creatinine ratio is more sensitive to those abnormalities. And for me, at least, it does make a difference if they have an elevated albumin to creatinine ratio. It could be 50, it could be 70, 90. It puts them into that A2 risk category, and I'm more likely to push, an ACE inhibitor or ARB, maybe titrate it if they have some blood pressure to go, or again, think harder about the SGLT2 inhibitors or other medicines like that. So.
All right. Any other questions before we let Dr. Heung go? All right, seeing none. Thank you, Dr. Heung. We really appreciate it.
Thanks, everybody.
Everybody's waving back to you if you can't see them. All right. Have a good night, Dr. Heung. Thanks.
Thank you.
All right. We have just a couple more slides to go. Try to get you out of here on time. Let me get back into slideshow presentation mode here. All right. So before we go, I'm gonna give you a couple of what's next slides. So we have hired a dietitian. They will be starting with us on the second week of May. And so they're going to hit the ground running with creating some low carbohydrate diet meal plans, as well as hosting some work groups for other dietitians or nutritionists or diabetes educators at your practices. More information about that will be coming out if there are anybody at your practices that feel like they would be interested in doing that. It'll be like a professional work group. They'll also be creating some patient-focused tools in addition to the meal plans, as well as hosting an online support group for patients. That might be a little bit further down the line, but we do want to make sure that we have support groups for patients that are interested in trying low carbohydrate meal plans and eating styles. That's something we're excited about. And we also have our patient advisory board. So we have had 3 meetings so far. We had one in November, one in February, and one in April of this year. We actually just had our April one last week. And these have been a big part of our guiding principle. So we want to make sure that everything we do in MCT2D keeps the patient voice as a central component. And so all of the tools that we make that are patient focused, we run by them, we give them a chance to look at them, make sure that the language that's used is appropriate and that it's something that they actually feel like they would use, that's something that's useful. And we take their feedback and we incorporate it. Our design team, Laria in the back, is able to really take their vision and put it into practice, and is something that we find very useful. Our next meeting for this is June 14th. If you do have other patients in your practice that you feel would be great candidates to participate in the board, we're always happy to have more members. They do get compensated for their time. It's a small amount. It's $15 for an hour meeting, but it is better than nothing. And we're always happy to have more members join. All right. Speaking of that, we have a short video, about a 2-minute video from one of our patient advisory board members, Shally. I'm going to play for you now.
I'm hoping that something can be done for the situations where people really need diabetes medication and don't have access to it, and they need them. My husband actually might pick it up, and he called me and he said, "This is $143." I said, "Well, don't pick it up, you know. We got to figure this out." Can I go through the history of all those type of meds, what I had to go through with that? So I did start on Trulicity, probably I'd say in maybe 2018 or 2019, somewhere in there. And I took it for quite a while, but I just could not tolerate the side effects. And it was very hard for me just to do my daily ADLs, I just couldn't do much. So switched me to Victoza, which was a dream. I was on Victoza until late last year. I tolerated it well. My weight was stable. My blood sugars were stable and low. I really was happy being on that. My husband's job changed and our insurance changed. And it turned out that we had to pay our medications full price until our deductible was met. So we paid 1 month for it, and then we just realized it's unattainable. You know, and in the end, it's be worth it, because wonder if I end up having to have a foot amputated or you know, something like that. And you know, $6,000 or $7,000 a year is worth keeping your limbs. But at this point, I mean, that's just more than a house payment. And my diabetic educator is just bent over backwards trying to find resources so that I can take that or another type. Yeah, we actually become friends through this because she's tried so hard to help me. She is the one who encouraged me to become a member of this team. I'm hopeful that, you know, I just would like to tell this story, but I want to be able to contribute to make a difference.
All right, yeah, so on top of the patient advisory board, we also have patient-reported outcome surveys that we've put together. There are packets of invitations for these in the back of the room if you do have patients that you think would be interested in participating in this. And so this is intended for patients who have been prescribed one of the 3 main focus therapies of MCT2D, whether that's CGM, one of the 2 medications, or a lower carbohydrate eating pattern. Like I say, they are 3 different surveys: a baseline, a 1 month, and a 1 year survey. And patients are compensated for their survey responses. They can earn up to $45 for that series of 3 surveys. There are packets of these invites in the back of the room. We have incorporated 3 different ways that patients can fill this out, including a low-tech option where they simply just call us, leave us a voicemail, and we'll call them back and complete the survey with them over the phone, so that technical capabilities are not a barrier. We also have a sheet of paper on your table. So this is what Dr. Richardson was alluding to earlier. We have partnered with the government liaison officer over at the American Diabetes Association, who is focusing on lobbying Medicaid to increase the coverage for CGMs for patients with type 2 diabetes. So there is a sheet of paper on your tables that is a sign up if you are interested in participating. Dr. Richardson is going to show that right now. If you would be interested in talking to him and providing your testimonial about your experience prescribing for patients with Medicaid, difficulties associated with that, as well as if you have any patients that have Medicaid that you feel would be interested in sharing their story and their struggles, it goes a long way to helping him advocate for this increased coverage. All right. Additionally, within the next couple of weeks or so, we're going to be launching our first edition of our Learning Community newsletter. So this is going to be a monthly periodical that will be sent out to all clinical champions at the POs and practices. We're hoping to have the first one out by April 29th. It might be the week after, but check your emails for this. This is going to contain a lot of great information pertaining to MCT2D, upcoming events, patient stories, and lots of new tools. Any new tools that we create will be included and introduced in this letter. And we also wanted to give you a heads up. So we are in the process of scheduling our October regional meetings. So we'll have a lot more information forthcoming for these. We're starting to finalize our dates. These will be in the same general regions. So yours will be around this area. We don't have it locked down yet, but look for an email within the next month or so about that. And the focus of that meeting is going to really be on discussing the quality improvement measures that MCT2D will be focusing on to start. And finally, thank you so much. We really appreciate you guys attending. If there are any questions or anything that you want to discuss, our coordinating center team, including Dr. Richardson and Dr. Oshman, will all be in the back of the room. We'll all be happy to talk to you. But thank you so much for coming out and get home safely.
And we're collecting the evaluations in the back corner as you walk out.
Yep, and we also can recycle your name badges if you don't want them. And there's a meeting evaluation for the meeting in your packet. If you would please fill that out. It's incredibly helpful for us.